everyone, and welcome to our deep dive, this time into the always fascinating world of clinical psychology.
It really is fascinating.
Yeah, we're going to be taking a close look at how it's changing, what the latest is, and what it all means, for us out here in the real world.
Absolutely.
And for this deep dive, we're going to be unpacking this pretty dense book, The Handbook of Psychology, Volume 8, Clinical Psychology.
It's a good one.
Yeah. And we're going to pull out, the juiciest, the most fascinating insights.
I think we've got some good ones.
Yeah. And don't worry, we're not going to make this like some boring lecture.
No, not at all.
Right. It's going to be a journey.
It is a journey.
Yeah, a journey of discovery.
Absolutely.
So
this handbook really tackles the big questions right off the bat.
like what?
What even a mental disorder?
Right.
It's not as straightforward as you might think.
You think it'd be a pretty simple question to answer.
Right.
But, it's so complex.
It is.
And
the handbook looks at all these different approaches.
yeah.
Like what they tried to do with the DSM-3. That's
Yeah.
the big guide that clinicians use to actually diagnose mental health conditions.
Right.
And then you've got Wakefield's harmful dysfunction idea.
Yeah.
He argued that just being unusual or different isn't enough for something to be a disorder. It's got to actually cause, real problems in someone's life.
Right. It can't just be, different. It has to actually be
Right.
harmful to the individual or
Harmful.
the people around them or something like that.
Exactly. And the funny thing is,
Yeah.
Spitzer, one of the main guys behind the DSM-3,
Yeah.
he actually called Wakefield concept a brilliant breakthrough.
Wow. A brilliant breakthrough.
Right.
So it really must have kind of shaken things up.
It did.
Yeah.
And I think it makes sense, though, because,
Yeah.
where do you draw the line between normal and disordered?
Right. Where's the line?
Yeah.
That's the thing. It's not always so clear.
It's not a bright line.
Right.
And the handbook also gets into this idea of diagnostic stability.
Yes.
Which is basically, how consistent are diagnoses over time.
So someone could be diagnosed with one thing today and a couple of years down the road have a different diagnosis.
Exactly. And it turns out it's not as stable as we'd like.
Huh. So what causes that to shift like that?
Well, it's complicated. Sometimes the actual symptoms change over time.
Right.
Sometimes it's, life experiences. The environment really affects your mental health.
Yeah. Life can throw some curveballs.
Absolutely, good and bad.
Yeah.
And the handbook even points out how the DSM-3 and DSM-IIR, those versions of the DSM, they actually cause some issues because of this whole stability thing. Because, how do you define something that keeps shifting?
Yeah, like nailing Jell-O to a wall or something.
Right, exactly.
Okay, well, let's get into some specifics here.
What's that?
The handbook dives into ADHD, which is often diagnosed in childhood.
And I find it so interesting that there's all this debate about whether ADHD is like its own thing, separate.
Yeah.
Or if it's maybe like an early warning sign of something else.
Right.
Like bipolar disorder in kids.
It's a big question,
Yeah.
Yeah. And it's not settled. The research is still going on. But the handbook, looks at this idea that what we call ADHD might actually be a piece of a bigger, more complex disorder that we just don't fully get yet.
Right.
And it also mentions this possible link between ADHD and the prefrontal cortex.
Okay.
That's the part of your brain that's in charge of planning, impulse control, all that.
Right.
And there's even some brain imaging studies
Oh, wow.
showing, there are actual structural differences in that area.
Oh, wow. So there could actually be
Yeah.
physical differences in the brain.
It's not just behavior.
Yeah.
It could be structural.
Right. Wow. But wait a minute. Doesn't the handbook also say that family factors play a part in all this too?
It does.
Yeah.
But it's important to note that even though family dynamics are, part of the equation,
Right.
negative family influences alone don't explain the whole thing.
Right. It's always nature and nurture.
Always both.
Right. Never just one thing.
Exactly.
Yeah.
It's like that saying, genes load the gun, environment pulls the trigger.
I like that.
Right.
Speaking of challenges during childhood,
Yeah.
another area that often pops up during those, crucial developmental years is anxiety disorders.
Oh, absolutely. And they're so common.
Right.
The average age of onset for generalized anxiety disorder or GAD is between 10 and 14.
Wow, that's young.
I know, right? During all that change in development.
Yeah, those are tough years.
Absolutely. And here's something that really struck me. Almost half of the teenagers with severe GAD still had it, even after 2 years, even without any treatment.
Wow. That's really concerning.
It is.
Yeah.
So intervening early is so important,
Oh, yeah.
you know?
Yeah, catch it early.
Exactly. And when it comes to the causes,
Yeah.
what causes it? The handbook really gets into the role of genetics and family history.
Okay.
And they found that kids with anxious parents,
yeah,
they're 5 times more likely to develop anxiety disorders themselves.
Wow, 5 times more likely.
I know, right?
So it's like it can be passed down but also learned, or?
Right, it can be both.
Yeah, wow.
It's really interesting how it's not always straightforward.
Right.
Yeah. Okay, so moving on.
Yeah.
The handbook also tackles schizophrenia.
Okay.
Which is known for showing up really differently in different people.
Right, yeah.
It's got what's called phenotypic heterogeneity.
Okay.
Which just means there's no single typical way it presents.
Yeah.
One person might have hallucinations while another person has, disorganized thinking.
Right, right.
And here's a crazy finding from the handbook.
Okay.
Even when they used very specific diagnostic criteria for schizophrenia,
Yeah.
there was still a ton of disagreement among the experts on who actually fit the diagnosis.
So even with our best attempts to categorize things, it's still a mystery.
Yeah, there's so much we don't know about schizophrenia.
Right.
So to try and explain this diversity, the handbook looks at something called the multifactorial polygenic model.
Okay.
Or the MFP.
MFP, got it.
This model basically says that multiple genes, not just one,
Right.
are interacting with environmental factors to increase someone's risk.
Right.
And all that complexity makes it really hard to study and treat effectively.
Yeah, it sounds like trying to solve a puzzle with a million pieces.
Right.
Okay, so we've talked about a few disorders that are often misunderstood. What about depression? I feel like everyone uses that word, these days.
Right.
But it's a real clinical diagnosis.
Absolutely.
With specific criteria.
It's not just feeling sad.
Right.
There's more to it.
Yeah, so what does the handbook highlight about diagnosing depression accurately?
Well, so if there's more to it than just feeling sad or down.
Yeah.
There are 4 key things clinicians look for to diagnose depression. First, there has to be a whole group of specific symptoms.
Right.
Not just one feeling.
Right.
Second, those symptoms have to last a while. We're talking weeks or even months.
Right, not just a bad day.
Not just a bad day.
Yeah.
Third, the depression has to actually impact your ability to function, day to day.
Right, it has to get in the way of life.
Exactly. And finally, there can't be any history of mania.
Right.
Those periods of super high energy.
Right.
Because that would point more towards bipolar disorder.
Right, right. So it's much more complex than just feeling blue.
It is.
For a bit.
Yeah.
Okay, so it's not just feeling blue, but it's interesting that the handbook points out that one of the tools used in a lot of studies, the diagnostic interview scale, or the DISC, it actually tends to underdiagnose depression.
Really?
Compared to when clinicians use interviews. That seems counterintuitive.
It does.
Doesn't it?
Yeah.
Because you would think the scale would be more accurate.
You'd think so.
But I guess it just shows,
how important the human element is.
Absolutely. Clinical judgment experience.
Yeah.
You can't replace that.
Right. That makes sense.
Yeah.
Sometimes a standardized tool just can't capture all those nuances of a person's experience.
Exactly.
Okay. Shifting gears a bit.
Okay.
Let's talk about bipolar disorder.
Okay.
This is a condition that is known for its really dramatic mood swings.
Absolutely.
Right. And the handbook really emphasizes the recurrent nature of bipolar disorder.
It's not just a one-time thing.
Right. It's not like you have one episode and you're done.
Right. It's marked by these cycles of depression and mania.
Right, up and down.
Up and down throughout your life.
Right. And these cycles could...
Oh, they can be so unpredictable.
Yeah.
The handbook talks about these consistent versus inconsistent polarity patterns.
Okay. So what's that all about?
So basically, some people with bipolar...
Yeah.
Their cycles consistently start with either depression or mania.
Okay, so it's always the same.
Always the same starting point.
Yeah, but then other people alternate.
Oh, so it's like depression, then mania, then depression.
And then back again.
Wow. So does it matter which way you start?
It's funny you should ask that.
Yeah.
Because the handbook actually mentions a study that found this really interesting correlation.
Okay.
The patients whose bipolar cycles always started with depression. They tended to have longer episodes and just worse outcomes overall.
Wow. So the way it starts can really impact the long term.
Yeah, the initial direction of the cycle seems to matter.
Wow. That's fascinating.
Isn't it?
Okay, let's move on to a category of disorders that I feel like we don't hear a lot about,
Okay.
but are actually pretty common
Yeah.
personality disorders.
These are the often overlooked ones,
right?
but they're surprisingly prevalent.
Yeah, and the handbook, goes into how the DSM-IV
Right.
categorizes them into 3 clusters.
3 clusters. So
Yeah.
you've got cluster A, which is all about the odd or eccentric behaviors,
Okay.
like paranoid personality disorder.
Right.
Then there's cluster B,
Yeah.
that's more of the dramatic, emotional,
Yeah.
erratic behaviors.
Right.
So like borderline personality disorder.
Okay.
And then cluster C
Yeah.
is the anxious or fearful behaviors.
Right.
Like avoidant personality disorder.
Okay, so these clusters are basically like a way of grouping
Looping them, yeah.
these personality disorders based on some common patterns.
Exactly.
Okay, so what else does the handbook highlight about these disorders?
Well, it points out that if someone has another mental health condition,
Yeah.
along with a personality disorder,
Uh-huh.
the outlook for that other condition is usually worse.
Oh, so it makes things more complicated.
Oh, complicated, yeah.
Wow.
And there's this really great quote from the handbook
Okay.
that I think sums up just how important it is to understand these disorders.
Yeah.
It says, in the DSM-3, then personality not only attained a nosological status of prominence in its own right, but was assigned a contextual role that made it fundamental to the understanding and interpretation of other psychopathologies.
Wow. So personality disorders aren't just important on their own. They can really provide a lot of context for understanding
Right.
and treating other mental health issues too.
All connected.
Yeah, it makes sense, you
Yeah.
know, because our personality shapes so much of how we see the world
It really does.
and how we interact with it.
Absolutely.
Okay, so let's talk about how these disorders are assessed.
Okay.
I know that clinicians use a few different methods,
They do.
each with their own pros and cons.
Right.
So walk us through that.
Sure. So you've got self-report inventories
Uh-huh.
where you answer questions about yourself.
Yeah.
Those are quick and efficient,
Right.
but they rely on you being self-aware and honest.
Right. You got to know yourself pretty well.
Exactly.
Yeah.
Then there are unstructured clinical interviews, which are more open-ended,
Yeah.
but they can be a bit less reliable because they're more subjective.
Right. It depends on the clinician.
It does.
Right. And then there's that sweet spot,
Yeah.
the semi-structured interviews.
Yeah, in the middle.
Yeah, which combine the best of both worlds.
The best of both worlds.
Yeah, but here's something I thought was kind of surprising.
Okay.
The handbook says that clinicians who use unstructured interviews,
Yeah.
they often miss key diagnostic criteria.
Really, even though they're trained professionals.
Yeah.
Huh.
You would think they would catch everything.
You would think.
But I guess it just shows how important it is to have, a structured
Right.
approach,
That's it.
even within a clinical interview.
It reduces the chances of missing something.
Right. It's like having a checklist.
Exactly.
So you don't forget anything.
Right.
Makes sense because, human memory
Right.
is not perfect.
Not perfect at all, even for experts.
Right. Right. Okay. I'm seeing a theme here. Structure and standardization are important.
They are.
But you also have to acknowledge, the complexity
Absolutely.
and the uniqueness.
The nuance.
Yeah, the nuance of each person.
Of each person.
Right. And that leads us perfectly into discussing a specific personality disorder,
Okay.
paranoid personality disorder, or PPD,
Okay.
right? PPD involves, this pervasive distrust of others.
Right. Suspicion.
Yeah, suspicion.
Yeah.
But it's relatively uncommon.
Yeah. It's not super common.
Right. And it's interesting that the DSM-IV
Yeah.
specifically cautions against over-diagnosing
Right.
PPD in people from different cultural backgrounds.
That's a good point.
Right, because what might seem like paranoia in one culture
Right.
could be totally normal in another.
Absolutely.
Right, that really highlights,
Yeah.
the need for cultural sensitivity.
Cultural sensitivity.
Clinical practice.
For sure.
Yeah.
Okay, so another personality disorder with its own unique challenges is avoidant personality disorder, or AVPD.
Okay.
And that involves, extreme social anxiety,
Okay.
fear of rejection,
Right.
all that.
Yeah.
And the handbook suggests that there might be a link
Okay.
between ADPD and the personality traits of introversion and neuroticism.
So it's like those treats taken to an extreme
Exactly.
could manifest
Right.
as a full-blown personality disorder.
That's the idea.
Wow, that's interesting.
So what does the handbook say about future research in this area?
Yeah, what's next for personality disorder research?
Well, it really emphasizes studying those early childhood experiences,
Okay.
to see if we can find any patterns
Yeah.
that might help us prevent or treat these disorders later on.
Right, like early intervention.
Early intervention.
Yeah.
Absolutely. And it also highlights the need to look at personality disorders as part of a bigger picture of how personality works in general.
Right. So it's not just about labeling disorders. It's about understanding...
Understanding the whole spectrum.
The whole spectrum
of personality.
Of human personality and how it all fits together.
Exactly.
Okay, so it sounds like, understanding personality is crucial not just for personality disorders, but for a whole range of mental health challenges.
Absolutely.
Right. Okay, speaking of which, our next stop on this deep dive is eating disorders.
These are tough ones.
Yeah, they are complex.
They are.
And often, really heartbreaking.
Absolutely.
And the handbook points out the overlap between eating disorders and mood disorders.
There's a connection there.
So like someone with anorexia might also be struggling with depression.
Exactly.
Yeah.
And the handbook actually cites a study that found that both genes and environment play a big role in increasing the risk for both anorexia and major depression.
There's that nature and nurture again.
Always.
Right.
Both.
Okay, so what else does the handbook say about the role of family in eating disorders?
So one study found that when parents encouraged their daughters to lose weight, that was a stronger predictor of those daughters developing restrictive eating
than the parents' own dieting habits.
Wow,
so it's like the messages we send.
The messages,
Even unintentionally.
Can
really have a big impact.
They can.
Wow, that's powerful.
It's not just about modeling behavior.
Right.
It's about how we talk about body image and food within the family.
Wow. Okay. And the handbook also looks at this complex relationship between childhood trauma and eating disorders.
Yeah.
Finding that the bulimic variations, the ones with the binge purge cycles, they might be even more strongly linked to difficult childhood experiences.
Trauma can play a role.
Yeah, past trauma could be a factor.
Absolutely.
Wow. Okay, so what about the genetic factors involved in eating disorders?
Well, family studies show higher rates of mood disorders among relatives of people with eating disorders like anorexia and bulimia.
Okay, so there seems to be a family connection there.
There does.
Yeah.
And the handbook talks about this concept called co-transmission.
Okay.
Where a genetic predisposition increases your risk for multiple related conditions.
Not just one.
Not just one. It's like having a key that can unlock several different doors.
Oh, that's a great analogy.
Right.
Yeah, so you might be predisposed to, a few different things.
Exactly.
Right?
And then to really isolate the impact of genes versus environment, the handbook talks about twin studies.
Right.
By comparing identical and fraternal twins, researchers can figure out, how much of a role genes actually play.
Wow, that's fascinating.
It is.
Okay, so get ready for a twist.
Okay.
Because we're going to dive into a topic that might surprise you.
Oh, I love surprises.
Disinhibition and impulse control disorders. All right, so what is disinhibition?
Basically, it's a personality trait, and it means having trouble controlling your impulses.
Right.
And as you can imagine, that can lead to all sorts of problems.
Like what?
Like substance abuse, gambling problems.
Oh, right. So it's that inability to resist temptation.
Exactly.
But I want it now, urge.
I want it now.
That gets us in trouble.
And here's a powerful quote from the handbook.
Okay.
That shows just how big a deal this trait can be.
All right.
It says, about 40% of the genetic susceptibility for alcohol dependence was shared with genetic variation in the personality dimension of behavioral under control.
Yeah.
Impulsivity, interpersonal exploitativeness, and social nonconformity.
So genes that make someone more impulsive can also make them more likely to struggle with alcohol.
Right. Those impulse control genes can unlock multiple problem doors.
Wow. Yeah. It's like they can't help themselves. It's like a drive.
Yeah. It's a drive.
Yeah.
And the handbook also discusses this complex relationship between extroversion, being outgoing and sociable, and impulse control disorders.
Right.
Sometimes extroversion can protect against these disorders.
Okay.
And sometimes it can actually increase the risk.
So it cuts both ways?
It depends. It's a complicated interplay of personality and behavior.
Yeah, I guess it's like walking a tightrope,
It is.
Trying to find that balance between being outgoing and social.
Right.
But also, staying in control.
Staying in control.
Yeah.
That's a great analogy.
And to make things even more complicated.
Right.
The handbook delves into the neurobiology of all of this.
Of course, we got to look at the brain.
Right. The brain. What's going on in the brain?
Right.
When it comes to impulsivity and these related disorders.
Exactly. So Research points to the involvement of some key neurotransmitters.
Okay.
Like serotonin, dopamine, norepinephrine.
Right, all those brain chemicals.
Those brain chemicals, they play a huge role in mood, motivation, and impulse control.
Right.
So if those neurotransmitters are out of whack, it can be much harder for someone to resist those urges.
So it's not just about willpower.
It's not. It has a biological component.
Yeah, a physical component.
A physical component.
To impulsivity.
To impulsivity.
That makes a lot of sense.
It does.
Okay, so let's move on to a category of disorders.
Okay.
Where disinhibition and impulse control play a huge role.
Okay.
Substance use disorders.
Substance use disorders.
Right.
The handbook explains how the DSM-IV distinguishes between substance abuse and substance dependence.
Yeah. Can you remind me what the difference is there?
Sure.
Because I always get those two mixed up.
Yeah, it's easy to do.
Yeah.
So substance abuse is when using a substance is causing problems in your life.
Okay.
But you're not physically or psychologically dependent on it yet.
Right.
Dependence is more severe.
Okay.
You might experience withdrawal symptoms.
Right.
If you try to stop and your life basically revolves around getting and using the substance.
Right, so it's a spectrum.
It is.
From problematic use to full-blown addiction.
To full-blown addiction.
Yeah.
And here's where it gets really interesting.
Okay.
The handbook talks about this debate in the research community.
Yeah.
About whether abuse and dependence are really different categories.
Right.
Or if they're just different points on the same spectrum.
So it's like, is it black and white or is it shades of gray?
Shades of gray. Yeah. That's the question.
Right. And I guess it emphasizes that there's still so much
we don't know.
That we don't know about this.
Exactly.
Okay, let's zoom in on one specific substance here.
Okay.
Alcohol.
Alcohol.
The handbook has a really interesting finding.
Oh, I love these findings.
About alcohol sensitivity. People at higher risk for alcohol dependence.
Right. So people with a family history of alcoholism.
Right.
They actually feel the effects of alcohol more strongly.
Oh, really?
When their blood alcohol levels are going up.
So they get a bigger buzz?
They get a bigger buzz from those first drinks.
Wow.
And then, get this.
Yeah.
As their blood alcohol levels start to fall, they actually experience fewer of the negative effects.
So their body's like encouraging them to keep drinking.
In a way.
Yeah. Wow, that's crazy.
This unique sensitivity pattern might explain why some people are just more vulnerable to becoming dependent.
Because they get more reward.
And reward.
At the beginning.
At the beginning.
And less of the punishment.
Less punishment.
Later.
Exactly.
Wow, that's wild.
Isn't it?
It shows how, biology and psychology can really be intertwined.
They're so intertwined.
Yeah, in these complex ways.
Absolutely.
Okay. Let's shift gears a bit and talk about how we train clinical psychologists.
Training.
Yeah. The handbook has a whole section on this.
It does.
Starting with the scientist-practitioner model, also known as the Boulder model.
The Boulder model.
Yeah, so remind me, what's the main idea behind this?
Okay, so the Boulder model is all about training psychologists to be both skilled clinicians and capable researchers.
Okay, so they're not just therapists, they're also scientists.
Exactly.
Right.
They're contributing to the research.
Yeah.
Building the knowledge base of the field.
Okay. And graduates from this model typically get a PhD.
That's right.
Right. PhD.
Okay. What are some of the other pathways?
Okay, so you've also got the practitioner-scholar model that leads to a PsyID.
Right.
This approach focuses more on developing those clinical skills and less on the research side.
So it's more about being a master therapist?
A master therapist.
Right.
Than a research scientist.
Less about the research, more about the practice.
Right, right.
And then
what if you want to do both?
There are a few programs out there that actually offer a combined PhD and PsyID track.
Oh, wow. Talk about a demanding program.
It's a lot.
Yeah.
But no matter which path aspiring psychologists choose, they have to meet some pretty strict licensing requirements to practice.
Of course.
The handbook goes into detail about the education and training sequence in the United States.
Yeah.
And get this, it takes at least 23 years.
23 years.
23 years.
That's longer than it takes to become a medical doctor.
It is.
Wow. So it's like 4 years of high school?
4 years of high school.
4 years of college.
4 years of college.
2 to 3 for a master's.
2 to 3 for a master's.
4 to 5 for a doctoral degree.
4 to 5 for a doctorate.
A year of internship.
A year of internship.
And then maybe even more.
Maybe even more.
For postdoctoral training.
Right.
Wow, it's like running an academic.
Marathon. That's a good way to put it.
Yeah, but that level of training, makes sense.
It does.
When you consider, the responsibility.
Yeah, you're dealing with people's mental health.
Right, you're dealing with people's lives.
Absolutely.
Yeah, okay. And that leads us right into the topic of ethics.
Ethics? Always important?
Yeah. What does the handbook emphasize about, ethical practice?
Well, it starts off by saying that ethical practice isn't just about following the rules.
Okay.
It's about aspiring to these high ideals
Yeah.
of the profession,
Mm-hmm.
and using moral reasoning
Okay.
to navigate all those complex situations that come up.
Right, because sometimes there's not a clear-cut answer.
Right, it's not always black and white.
Yeah, so it's not just about checking boxes.
It's not just checking boxes.
Yeah.
It's about having a strong moral compass.
Right, and letting that compass guide you.
Exactly.
Okay. And the handbook also talks about, how those ethical codes are enforced.
Right.
And how important it is for psychologists to, stay up to date.
Well, absolutely.
Because they're always changing.
They're always evolving. What might have been okay, 50 years ago
Right.
might not be acceptable today.
It's like a living document, adapting to the changing world.
It's a great analogy.
Okay, so speaking of changing world, one of the biggest shifts in mental health care, over the past few decades has been managed care.
Oh, yes, managed care, that double-edged sword.
Right, the double-edged sword of mental health care.
Yeah.
So what does the handbook have to say about that?
Well, it really digs into the impact of managed care,
Okay.
looking at both the good and the bad.
Okay, so what are some of the pros and cons?
Well, on the plus side,
Yeah.
managed care has definitely made mental health services more accessible
Right.
to people who might not have been able to afford them otherwise.
Right, because therapy can be expensive.
It can be very expensive.
Yeah.
And it's also led to more accountability
Okay.
and efficiency in treatment.
So treatments have to be more evidence-based?
Evidence-based and focused,
Yeah.
which is good for patients.
Right.
But on the downside,
Yeah.
a lot of therapists feel like managed care limits their options.
Right.
And interferes with their clinical judgment.
Yeah, it's like the insurance companies are trying to dictate,
Right.
how therapy should be done.
They're trying to control things.
Right. Which seems problematic.
It can be.
Yeah.
The handbook really gets into those ethical dilemmas that come up when you're working within a managed care system.
Right.
And it encourages therapists to, be aware of these challenges.
Right.
And really advocate for their patients' best interests.
So it's like finding that balance.
Finding that balance.
Between providing quality care.
Yes.
And working within the constraints.
The constraints of the system.
Yeah.
Exactly.
Okay. And speaking of a changing landscape.
Okay.
We can't forget about technology.
Technology is everywhere.
Right. And it's definitely impacting the world of clinical psychology.
Absolutely. The digital age has arrived in the therapy room.
It has.
The handbook has a whole chapter on this,
Really?
exploring how technology is changing things.
So, what are some examples?
Well, one big one is teletherapy.
Oh, right. Teletherapy.
Where therapists can provide services remotely.
Right, through video conferencing?
Through video conferencing, you can literally have a therapy session with someone across the country.
Wow, that's amazing.
It is.
So that's really increased accessibility.
It has.
For people in rural areas or?
Rural areas.
People with mobility issues?
Absolutely. Anyone who has trouble getting to a therapist's office,
right.
It's been a game changer.
That's awesome.
But of course, there are challenges.
Right. I imagine there are ethical considerations.
Yes, there are.
Yeah, like confidentiality.
Confidentiality, licensing issues.
Yeah, different states have different laws.
Exactly. And making sure the quality of care is the same.
Right. Because it's a different setting.
It's a different setting.
Yeah, it's like we're navigating uncharted territory.
We are.
It's
the Wild West of therapy.
Yeah, we need new guidelines.
New guidelines.
For ethical and effective practice.
Absolutely.
In this new digital age.
Digital age.
Yeah. Okay, so what about other technological advancements?
Okay, so another exciting area is virtual reality.
Oh, wow.
VR is really pushing the boundaries.
So how are therapists using VR?
Well, they're using it to create these immersive simulations that help patients confront their fears or practice new skills in a safe and controlled environment.
So like someone who's afraid of public speaking?
Exactly.
Could practice giving a presentation?
In front of a virtual audience.
Wow.
To get comfortable before doing it in real life.
That's amazing.
It is. And the handbook even mentions a study. Where they used VR to treat acrophobia.
Acrophobia, that's the fear of heights.
Fear of heights.
Right.
And it worked by gradually exposing people to virtual heights.
Right. So their brain learns that it's not actually dangerous.
Exactly.
Wow, that's so cool.
It is.
What other conditions could VR be used to treat?
Oh, the possibilities are endless.
Yeah.
Researchers are looking at PTSD, social anxiety, even substance use disorders.
Wow, so it's like a whole new toolbox.
A whole new toolbox.
And techniques to help people face their challenges.
And it's really exciting.
Yeah, it is exciting.
But it can be a bit overwhelming, too.
Right, because it's so new.
It is new.
And there are so many possibilities.
So many possibilities.
Yeah, but as technology keeps developing, it's important that we as clinicians, we embrace these new advancements, but we have to be mindful.
Mindful of the ethics.
Yeah, of the ethics.
Absolutely. And most importantly, we can't forget about the human connection.
Right.
That's at the heart of therapy.
The human connection is so important.
It is.
Yeah, it's about using technology to enhance that connection.
To enhance it.
Yeah.
Not replace it.
Not replace it, exactly. Okay. So the handbook also emphasizes the role of advocacy in clinical psychology.
Advocacy, yes. That's a big one.
It says that clinical psychologists have a responsibility to advocate
responsibility
for mental health issues, not just in the therapy room,
right,
but also in the community and in society as a whole.
Absolutely. It's about being a voice for those who might not be able to speak for themselves.
Right. So it's not just about working with clients one-on-one.
It's bigger than that.
Yeah, it's about speaking up.
Speaking up.
For those who are struggling.
Yes.
And pushing for change.
Pushing for change.
At a systemic level.
Exactly.
Wow. So what are some examples of advocacy work that clinical psychologists can do?
Oh, there's so many possibilities.
Yeah.
We can advocate for policies that support mental health care access and funding.
Right.
We can challenge the stigma and discrimination that surrounds mental illness.
Absolutely.
We can promote mental health awareness in our communities.
Right. So it's about being active citizens.
Active citizens.
Using our knowledge.
Our expertise.
To make a difference.
To make a real difference.
Yeah, beyond our individual practices.
Absolutely.
So how can clinical psychologists get involved in advocacy?
Well, we can write letters to our elected officials.
Okay.
We can speak at community events.
Yeah.
Volunteer with mental health organizations.
Right.
We can even run for office ourselves.
Wow, so many ways to make a difference.
There are.
And the handbook says that even small actions can have a big impact.
They can.
Yeah, so even if we're not, lobbying Congress or running for office, we can still contribute by raising awareness and challenging stigma
in our own
circles.
Yeah, in our own lives.
Exactly. Every voice counts.
Right.
And the more people who speak up about mental health, the more likely we are to create a world where everyone feels supported.
Right.
And empowered to seek help when they need it.
Absolutely. Well said. Okay, let's shift gears again here and talk about the efficacy and effectiveness of psychotherapy.
Does therapy actually work?
Right. Does it really work?
That's the big question.
Yeah.
And the handbook really dives deep into the research.
Yeah.
The overall answer is a resounding yes.
Okay, so therapy does work?
It does.
But I'm guessing it's not quite that simple. You're right, it's not a magic cure-all.
Right.
And not every type of therapy works for every condition.
Okay.
But overall, the research shows that psychotherapy is more effective than no treatment at all.
Okay.
And it can even be more effective than medication for certain conditions.
Wow. So you're saying that in some cases, talking to a therapist can be more helpful than taking medication?
That's right. But of course, finding a therapist who's a good fit for you and who uses evidence-based approaches, that's crucial.
Right. You got to find the right therapist for you.
It's like finding the right key for the lock.
I like that.
The therapy needs to match the individual and their specific needs.
That makes sense, but the handbook does acknowledge that therapy is not a guaranteed success.
It's not.
And for everyone.
Some people don't respond to treatment.
Yeah.
Others drop out before they can benefit.
Right.
And unfortunately, a small percentage might even experience negative effects.
So it's important to be realistic. About the limitations. Of therapy.
Of therapy.
Yeah, and recognize that it's not a perfect solution.
Not a perfect solution.
For every single person.
Not for everyone.
Right.
And that highlights the responsibility we have as therapists.
Yeah.
To keep learning and improving our skills.
Right.
To provide the best care possible.
Right.
But also to acknowledge that we don't have all the answers.
Right. There's always more to learn.
Always more to learn.
Okay. I know there are a lot of different approaches
Yeah,
to psychotherapy, each with its own unique perspective.
different schools of thought.
Yeah, so can you walk me through some of the main ones?
Yeah.
Like, what are the different ways of thinking about therapy?
Okay, so the handbook starts with psychodynamic psychotherapy,
Okay.
which has its roots in Freudian theory,
Yes, the classic talking cure.
the talking cure.
Yeah. So remind me, what are the core principles of psychodynamic therapy?
So psychodynamic therapy is all about exploring those unconscious processes.
Okay.
Understanding how past experiences, especially childhood experiences,
Yeah. Right.
shape our present behavior
Okay.
and working through those unresolved conflicts.
So it's about digging deep into those childhood memories.
Digging deep.
Yeah, and uncovering those hidden patterns.
Uncovering those patterns.
That are driving our behavior today.
Exactly.
Okay.
And the handbook points out that psychodynamic therapy has evolved over time. It's moved away from that traditional long-term analysis.
Okay.
And embraced shorter, more focused approaches.
So even Freud is getting a modern makeover.
Even Freud.
Okay. What are some of the other approaches?
Well, in contrast to the depth-oriented approach of psychodynamic therapy, you have behavioral therapy.
Behavioral therapy.
Which focuses on changing behaviors through reinforcement and conditioning.
So that's the one with all the rewards and punishments, right?
Rewards and punishments, that's the one.
Okay.
Behavioral therapists work on identifying and modifying maladaptive behaviors.
Okay.
Through techniques like exposure therapy and systematic desensitization.
Okay, can you give me an example of that?
Sure. So someone with a phobia of spiders might gradually expose to spiders in a controlled setting.
Oh, okay. To help them overcome their fear.
Exactly. It's about retraining the brain.
Right.
To respond differently to those triggers.
Okay, so it's like exposure therapy is like facing your fears.
Facing your fears.
But in a safe way.
In a safe and controlled way.
Right. Okay, and the handbook explains how behavioral therapy has evolved too.
It has.
Right.
It's incorporated cognitive techniques to address the thoughts and beliefs that contribute to those problematic behaviors.
So it's not just about changing actions.
Right.
It's about changing the thinking.
Changing the thinking.
That drives those actions.
Exactly.
Okay.
And that brings us to cognitive behavioral therapy, or CBT.
CBT. Okay, I've heard a lot about this one.
CBT is very popular.
Yeah, it's like the big one these days.
It is one of the most popular and well-researched approaches out there.
So what makes it so effective? Well,
CBT is based on this idea that our thoughts, feelings, and behaviors are all interconnected.
So if you change one,
you change the others.
Yeah.
Exactly. So CBT therapists help clients identify and challenge those negative or distorted thinking patterns.
Right.
That contribute to emotional distress and problematic behaviors.
So it's like becoming aware of those automatic negative thoughts.
Yes, those automatic thoughts.
Yeah.
And learning to reframe them.
Reframe them in a more positive and realistic way.
More positive and realistic.
Yeah, it sounds like a really powerful tool.
It can be.
Yeah, for self-management.
For self-management.
Right, and the handbook highlights all this research.
Research is impressive.
That shows how effective CBT is for so many different things.
So many things. Anxiety, depression, PTSD, even substance use disorders.
Wow, it's like the Swiss Army knife of therapy.
I love that analogy.
Yeah, you can use it for so many different challenges.
So many challenges.
Okay, so CBT focuses on this interplay of thoughts, feelings, and behaviors.
Right.
But humanistic therapy takes a very different approach.
A very different approach.
Yeah, so tell me more about the humanistic perspective.
Okay, so humanistic therapy.
Yeah.
It emphasizes the individual's inherent capacity for growth.
Okay.
And self-actualization.
Okay, so it's like you have the power within yourself.
You have power within.
Yeah, to heal and grow.
To heal and grow.
Okay.
It's all about creating this safe and supportive environment.
Yeah.
Where clients can explore their feelings, their values, their goals without judgment.
So it's more about empowering the client to find their own answers than providing specific techniques or interventions?
It's about trusting the client's own inner wisdom.
Okay, so it's less about the therapist being the expert.
It is.
And more about the client being the expert on their own life.
Exactly.
Okay, and the handbook highlights some of those key principles.
Those key principles.
Of humanistic therapy.
Yeah, things like empathy, unconditional positive regard, and genuineness on the part of the therapist.
So it's about creating that deep, authentic connection.
Deep, authentic connection.
Yeah, and helping the client tap into their own inner wisdom.
Their own inner wisdom.
I love that. And I know there are a few different approaches.
There are.
Within this humanistic tradition.
Right.
Can you tell me a little bit more about those?
Sure. So The Handbook talks about client-centered therapy.
Okay.
And Gestalt therapy.
Okay.
So client-centered therapy was developed by Carl Rogers.
Okay.
And it's all about creating this therapeutic relationship where the client feels truly heard and understood.
Okay.
So the therapist reflects the client's feelings and thoughts back to them.
Okay.
To help them gain clarity and insight.
It's like holding up a mirror to the client.
Holding up a mirror.
Right, helping them see themselves more clearly.
More clearly.
Okay, what about Gestalt therapy?
So Gestalt therapy focuses on bringing awareness to the present moment.
Okay.
And helping clients integrate different parts of themselves.
Okay.
So Gestalt therapists might use techniques like role-playing.
Okay.
Or the empty chair technique.
Okay, I've heard of that one. What's that?
So the client imagines someone they have a conflict with.
Okay.
Sitting in an empty chair.
Uh-huh.
And they talk to them.
Oh, wow. So they're working through that conflict.
Working through the conflict.
Yeah.
By talking to the empty chair.
Interesting.
Right.
Okay, so it's about being present.
Being present.
Yeah.
Aware of your thoughts, feelings, and behaviors in the here and now.
Right.
And learning to accept and integrate all those parts of yourself.
So it's about wholeness.
Wholeness.
Yeah.
Integrating everything.
Okay.
And both client-centered and Gestalt therapy emphasize the importance of that therapeutic relationship.
Okay.
And the client's own inner capacity for healing and growth.
Okay, that's really interesting.
It is.
Okay, so we've explored, a range of individual therapy approaches.
Right.
What about group therapy?
Group therapy.
Yeah, what are the benefits of that?
Well, group therapy gives people a chance to connect with others who are facing similar challenges.
Right.
And it can provide this amazing sense of belonging and understanding.
Right, because you're not alone.
You're not alone.
Yeah.
People can share their experiences, offer support to one another, and learn from each other's journeys.
Like a built-in support system.
It is, where everyone's in the same boat.
Everyone's in the same boat.
Yeah.
Okay, so what are some of the different types of group therapy?
Okay, so you've got psychodynamic groups.
Uh-huh.
Cognitive behavioral groups, and support groups.
Okay, so the type of group would depend on,
It depends on the needs and goals.
The needs and goals of the participants.
Exactly.
Right? So like a psychodynamic group.
A psychodynamic group might focus on exploring those unconscious processes.
Okay.
While a cognitive behavioral group would work on changing negative thinking patterns.
Right.
And developing coping skills.
And a support group is more about providing emotional support and that sense of community.
Exactly.
For people who are dealing with a specific issue.
Right, like grief or chronic illness.
Right, okay.
And the Handbook talks about the important role of the group leader.
Right.
Who's responsible for creating that safe and supportive environment.
Right, because you need someone to kind of guide the group.
You need a guide.
Yeah.
To make sure everyone feels comfortable sharing.
Right.
And working through their issues.
Yeah, and I imagine that's a really challenging role.
It can be.
Yeah.
You're managing group dynamics.
Yeah.
Making sure everyone feels heard and respected.
It's like herding cats.
Herding cats.
But with a therapeutic twist.
Exactly.
Okay. What about family therapy?
Family therapy. Yeah. So family therapy focuses on the family unit as a whole.
Right. Not just the individual.
Not just the individual.
Yeah.
Family therapists see the family as a system.
Okay.
Where each member's behavior influences and is influenced by the others.
So it's like a web of interconnectedness.
It is a web.
Right.
It's about understanding that interconnectedness.
Right.
Not blaming any one person for the problems.
Well, yeah, because everyone's contributing.
Everyone's contributing
to
the dynamic.
Yeah.
And change requires a shift in the whole system.
Not just one person.
Not just one person.
Right.
Everyone has to be on board.
Okay. The Handbook talks about a few different family therapy approaches.
It does.
Right. Can you give me a quick rundown of those?
Sure. So you've got structural family therapy.
Okay.
Which focuses on changing the family's structure and organization.
Okay.
Often by clarifying boundaries and roles.
Okay.
Then there's strategic family therapy.
Okay.
Which uses these creative techniques.
Okay.
To disrupt those problematic patterns and promote change.
So like what kind of creative techniques?
Well, for example, a therapist might give the family a seemingly strange task.
Okay.
To complete together.
Uh-huh.
Which forces them to interact in new ways and break out of their usual routines.
So it's like shaking things up.
Shaking things up.
Yeah, to get them out of those ruts.
Exactly.
Okay. What about Bowenian family therapy?
So Bowenian family therapy is more about understanding those multi-generational patterns.
Okay.
That influence the family's current dynamics.
So it's like looking at the family's history.
Looking at the history.
Right.
And how those legacies from previous generations are playing out in the present.
So it's like the family story didn't start with this generation.
Exactly.
Right. It goes way back.
It goes way back.
And those historical patterns, can continue to shape how they relate to each other.
It can be very powerful.
Wow, that's fascinating.
It is.
Okay. And the handbook also emphasizes, the importance of cultural competence in family therapy.
Of course.
Right? Because families come in all shapes and sizes.
All shapes and sizes.
And cultural backgrounds.
And cultural backgrounds.
Right. So you can't take this one-size-fits-all approach.
Absolutely not.
Right. You have to be sensitive to the unique cultural values. And beliefs.
And
communication styles.
Communication is key.
Of each family.
That you work with.
Exactly.
Okay. So we were talking about, different training paths for clinical psychologists.
Right.
But the handbook also delves into crisis intervention. Which seems like a completely different world.
It's a very specialized area.
Yeah. So what is crisis intervention all about?
Crisis intervention is all about providing immediate support.
Okay.
And stabilization.
Yeah, okay.
To people who are experiencing an acute crisis.
Okay, so like after a traumatic event.
Exactly, like after a traumatic event.
Okay.
It's about helping people navigate those intense emotions.
Right.
And the practical challenges.
Yeah.
That come with a sudden, unexpected event.
So like a natural disaster or a violent crime.
Exactly.
Wow, so it's like being a first responder.
It is.
But for mental health.
It's like mental health first aid.
Right, you're providing a lifeline.
A lifeline.
For someone who's been thrown off balance.
Yeah. That's a great way to put it. Okay. And the handbook also talks about specific models of crisis intervention.
Right.
Like critical incident stress debriefing or CISD.
CISD.
Okay, so what's that all about?
So CISD is this structured group intervention.
Okay.
That's often used after traumatic events.
Okay.
Like mass shootings or natural disasters.
Right.
It's designed to help people process what they've been through.
Okay.
Cope with the emotional fallout.
Right.
And hopefully prevent long-term psychological problems.
So it's like group therapy, but specifically for people who've experienced a shared trauma.
Exactly, a shared trauma.
Yeah, but the handbook mentions that there's some debate about how effective CISD actually is.
There is. More research is needed.
So it's not a guaranteed solution.
Not a guaranteed solution.
And we need to be careful about assuming it's the right approach.
Right. It's not one size fits all.
Yeah, for every situation.
Not for every situation.
But regardless of the specific model, having trained crisis intervention specialists available to provide support in those times of need.
It's crucial.
Yeah, because in those moments of acute distress,
right,
having someone who's skilled and compassionate to turn to can make all the difference.
It can be life-saving.
Yeah, okay. The handbook also has a whole chapter on psychotherapy with older adults. Yeah, which makes sense because mental health doesn't stop being important as we age.
No, it doesn't.
Right. And the handbook highlights, the unique challenges. In consideration
of working with this population.
Yeah, for one thing.
Yeah.
Older adults might be facing age-related issues.
Right.
Like retirement.
Right.
Loss of loved ones.
Yeah.
Declining physical health.
Yeah. Those are all big transitions.
They are big transitions.
Yeah.
And they can bring up a lot of emotions.
Yeah.
That weren't there earlier in life.
Right. So a therapist working with older adults needs to be sensitive.
To those developmental changes.
And
life experiences.
That
come with aging.
Absolutely.
Yeah. And there's also, cognitive decline to consider.
Right.
Dementia.
That makes sense.
Which can really impact the therapy process.
It can make things more complicated.
Yeah. You might have to adapt your techniques.
Your
communication style.
Communication is key.
To meet the needs of someone.
To meet their needs.
With those cognitive impairments.
Exactly.
Yeah. It seems like working with older adults requires a lot of flexibility.
It does.
And specialized knowledge.
Yeah.
Okay. And the handbook also emphasizes incorporating a life review. A reminiscence. Into therapy.
With older adults.
It's so important.
So it's like helping them process their life experiences. Finding meaning. In their stories. And coming to terms with the past. And research actually suggests that life review and reminiscence can reduce depression.
Really?
and improve well-being.
Wow. So it's like weaving together the threads of their life story.
Weaving together the
To
thread.
help them find peace and closure.
Peace and closure.
That's beautiful.
It is.
Okay, so are there specific therapies that are more effective for older adults?
So the handbook highlights some strong evidence for behavioral and environmental interventions for older adults with dementia. These focus on modifying the environment and teaching caregivers strategies to manage challenging behaviors.
So it's more about adapting the surroundings.
Adapting the surroundings to meet their needs.
Yeah, instead of trying to change the person.
Exactly.
Yeah. Okay, and for clinical depression in older adults, it seems like a lot of different approaches can be helpful.
It does seem that way.
Right.
Psychodynamic cognitive behavioral treatments. They've all been shown to be effective.
So again, it's about finding that right fit.
It's a right fit.
Between the therapist and the client.
It's always about the fit.
Yeah.
It's so crucial no matter the age group.
Right. Okay. What other interesting things does the handbook say about therapy with older adults?
Well, it notes that working with this population seems to push therapists towards a more eclectic approach.
Okay, what does that mean, eclectic?
It means they draw from different schools of thought. And tailor the therapy to each individual client. You know, their needs, their personality.
So it's not about sticking to one specific approach.
Not rigidly, no.
Yeah.
It's about being flexible. Using what works best.
Using different techniques.
Depending
on what the client needs.
In the moment.
It's like therapy becomes a dance.
It's a beautiful analogy.
Yeah.
It really captures the spirit of effective therapy with older adults.
Right. The therapist and the client are working together.
To
find that rhythm. That works for them.
Exactly.
Yeah, I love that. Okay, so we've explored a variety of therapy approaches and settings.
We have.
But this deep dive wouldn't be complete without talking about technology's impact on clinical psychology.
You're absolutely right. Technology is changing the landscape of mental health care in some really profound ways.
It's amazing and a little bit scary.
Yeah.
But, we talked about teletherapy and VR.
Yeah.
But those are just the tip of the iceberg.
The tip of the iceberg.
Right.
The handbook really encourages psychologists to embrace these advancements, but always with those ethical considerations in mind.
Right. It's about using technology to improve lives.
But
not at the expense of, those ethical considerations.
Exactly. Technology is a tool.
Right.
And like any tool, it could be used for good or for bad.
Right.
It's up to us as clinicians and researchers to make sure we're using it responsibly and ethically.
So what are some of the ethical things we should be thinking about?
Okay, well, for starters, confidentiality.
Right.
With teletherapy and online platforms, protecting client privacy is more important than ever.
Right.
We also need to think about accessibility.
Right. Not everyone has the same access to technology.
Not everyone does. And we need to make sure that these advancements don't make that gap even bigger.
Right. So technology has the potential to make mental health care more accessible.
It does.
But only if we're really intentional about addressing those disparities.
Absolutely. We have to be mindful.
Right. Okay. What about the therapeutic relationship itself?
Ah, yes. The heart of it all.
Can technology really replicate that human connection that's so vital to healing?
That's the million-dollar question, isn't it?
It is.
Technology can certainly enhance the therapeutic relationship in some ways.
How so?
Well, it can make it easier for clients to connect with their therapist between sessions.
Right.
Or it can provide access to resources and support groups online.
Right.
But we have to remember, technology can't replace the human element of therapy. The empathy, the compassion, the shared understanding.
Yeah.
That comes from a genuine human connection.
That face-to-face, heart-to-heart connection.
Exactly.
Yeah, so it's about finding that balance. Right.
Between using technology to enhance the relationship without letting it become a barrier to that connection.
Right. Using technology thoughtfully. Intentionally.
Essentially. Always putting the client's needs first.
Always the client's needs first.
Right. Okay. And speaking of the client's needs, the handbook also talks about the role of advocacy.
Advocacy, yes.
Right. And it argues that clinical psychologists have a responsibility to advocate for mental health issues, not just in the therapy room, but in the wider community and in society as a whole.
Absolutely. Advocacy is crucial. It's part of our job.
So we have this unique understanding
of
the challenges people face.
We see it every day.
Right.
And we have a responsibility to use our voices.
To make a difference.
To make a difference, to create positive change. Yeah, so what are some examples of that? What can we do?
We can advocate for policies that support mental health care access and funding.
Yeah.
We can challenge the stigma and discrimination.
Right.
We can promote mental health awareness.
Right. In our communities?
In our communities, in our workplaces, in our families.
So it's about being active citizens.
Active citizens.
Using our knowledge.
Using our knowledge.
And our influence.
Our influence.
To make a difference.
To make the world a better place.
Yeah, beyond our individual practices.
Absolutely.
Okay, so how can we get involved? Like, what can we do?
Well, we can write to our elected officials.
Okay.
Speak at events. Volunteer with organizations.
Yeah.
We can even run for office ourselves.
Wow, so many ways to make a difference.
So many ways.
Right, and the handbook emphasizes that even small actions...
Even small actions...
have a big impact.
They can have a ripple effect.
Yeah. So even if we're not, lobbying Congress or running for office...
Right.
We can still contribute by raising awareness and challenging stigma.
In our own circles.
Yeah, in our everyday lives.
Exactly.
Right. Okay.
Every voice matters.
Every voice matters.
Yeah.
Okay. So as we kind of wrap up this deep dive,
okay,
the handbook leaves us with some pretty thought-provoking questions.
It does.
About the future of clinical psychology.
It does.
What are some of those big challenges and opportunities that we're facing?
Well, one challenge is the growing demand for mental health services.
Right. More and more people are seeking help.
The stigma is decreasing,
Yeah.
which is great.
It is great.
But there simply aren't enough qualified providers to meet that demand.
It's a good problem to have in a way.
It is a good problem.
Right.
But it's still a problem.
It's still a problem if people can't get the care they need.
Exactly.
Right. So we need to train more psychologists.
More psychologists.
And find ways to expand access to care.
Expand access.
Especially in those underserved communities.
Especially in those communities.
Right. So it's about building capacity.
Building capacity.
Within the system.
Within the system.
Yeah. So people can get the help they need when they need it.
Exactly.
Okay. What other challenges and opportunities are out there?
Well, as we've talked about, technology is really changing everything.
It is.
Teletherapy, VR, artificial intelligence.
Yeah.
These are just a few of the things that are changing how we deliver and receive care.
Right. And it's exciting.
It's exciting.
But it also raises a lot of questions.
It does.
Right? Like, how do we make sure technology is used ethically?
Ethically.
How do we prevent it from widening the gap?
That gap between the haves and have-nots.
Yeah.
Right?
Yeah.
How do we maintain that human connection?
That human connection.
That's so essential.
So essential.
To healing in this increasingly digital world.
Big questions.
Big questions, yeah.
We need to be talking about these things as a field.
Yeah.
Developing guidelines, best practices.
Right.
Making sure we're using technology in a way that benefits everyone.
Right.
Clients and therapists.
Right. It's about finding that sweet spot.
That sweet spot.
Where technology enhances our humanity.
Right. Not diminishes it.
Not diminishes it.
Yeah, I love that. Okay, and I guess this brings us to the biggest challenge of all.
The big one.
Defining mental illness itself.
The ultimate question.
Right.
What is mental illness?
Right.
We've talked about the DSM
yeah.
and these attempts to categorize things.
Right.
But the truth is, mental illness is messy.
Yeah.
It's complex. It's multifaceted.
Yeah.
It's not always easy to say what's normal and what's a disorder.
Right. Where's the line?
Where is the line?
Right.
And as our understanding of the brain, genetics, human behavior,
yeah.
all of that evolves,
yeah.
our definitions of mental illness will probably evolve too.
It's like we're always learning more.
Always learn.
Refining our understanding of what it means to be human.
What it means to be human.
Yeah.
In all our complexity.
In all our messy glory.
In our messy glory.
Okay, well, I think we've officially reached the summit of this deep dive.
We have.
Yeah.
We've explored so much.
We have the history, the theory, the research, the practice of clinical psychology.
It's been quite a journey.
It has.
And we've uncovered so many insights into how this field is changing.
Yeah, what the future holds.
What the future holds.
Yeah. My brain is definitely full.
I bet.
But I'm feeling really inspired.
I am too.
And hopeful.
Hopeful about the future.
About the future of this field.
Yes.
And the impact we can have.
The impact we can have as clinicians, researchers, advocates.
As human beings.
As human beings.
Mm-hmm. Yeah. And to all you deep divers out there listening, keep those curious minds engaged. Keep asking questions, keep seeking knowledge, and keep pushing the boundaries of what's possible when it comes to understanding and supporting mental health.
Well said.
Because the more we learn about the human mind, the better equipped we'll be to create a world where everyone can thrive.
Absolutely.
So until next time, happy exploring.
Happy exploring.